state info based upon who I think is going to be joining the call on what exchanges are and how they're going to be implemented in your state. Some legislative history and a regulatory timeline for essential health benefits so you can see how we got to where we are today. The state's role in defining what essential. I'll get specific into habilitation. I'll talk a little bit about the non-discrimination protections that are supposed to surround essential health benefits package. And then I'll do a little bit of comparing where your states are at in terms of defining and mandating coverage for rehabilitation and habilitation services and devices specifically. So a quick overview of health insurance exchanges. What's supposed to occur here is they're supposed to be creating each state a new marketplace. And this marketplace is meant to be basically a virtual market where consumer health insurance plans can go online. Those could be individuals or small employers, or they potentially can go into an office in their state and they can purchase insurance, and they can purchase insurance and compare plans across a variety of issuers. So, you know, the analogy would be Orbit or Kayak, where you can now go online and compare prices and flights. And the idea would be that you could do the same for an insurance plan. This is supposed to, one, open up a new market for issuers and providers, a new market of previously uninsured individuals and employees of small group plans or small employers. And two, it's supposed to provide competition to help bring down the cost of insurance plans. So it forces competition. It allows consumers more information and transparency about the differences in plans and what benefits are covered, and it allows them more transparency in pricing. Now, some of these exchanges will be entirely state-based. Maryland and Nevada are going to be operating their own state exchange. Many states, however, have chosen to either partner in operating their exchange or default and allow the federal government to operate their exchange entirely, at least in 2014. There are a variety of reasons for states to do this, ranging from the political just to the practical and logistical. Some states have a stronger public health infrastructure already in existence, and I think I would say that Maryland is one of those states, and so they were able to take this and run with it, and I think are well on their way of being ready come October when people are starting to enroll in the new plans. But there are other states who may not have that public health infrastructure or, frankly, the political will to change right now. Florida and Texas, from what we can tell right now, the federal government will their exchange in 2014. It's important to know that this is not a federal exchange in the sense of all of these and citizens in each of those states will be grouped together. Those plans will still be state-based, even though Texas, say, may have HHS operating their exchange for them. Those insurance plans are going to be based in Texas, and they're going to be purchased by individuals that reside in Texas. So in essential health benefits, a brief legislative history. We all know in March 2010, the Affordable Care Act was passed. The Affordable Care Act sets a minimum benefits coverage standard in order to assess whether the loss requirements are met. And the loss requirements are basically as follows. Individuals starting next year will be required to have insurance coverage. So for those individuals out there right now who do not have insurance, there will be a requirement that they purchase insurance or they will pay a fine when it comes time for them to file their taxes. The other requirement, the sort of other side of that coin, is that now insurance plans must guarantee coverage. So they can no longer deny individuals based upon pre-existing conditions or something in their health status or history. So this sort of the idea of the law is to bring plans and consumers together, expand coverage to those that are otherwise uninsured, and ensure coverage for those who were not able to get it in the past because they had a pre-existing condition. So specifically, in order to meet those requirements, in order to say, okay, individuals, you have to go purchase insurance, there has to be a standard by which that requirement is met. So what kind of insurance must they purchase in order to meet that requirement? In the same way, what kind of insurance must issuers offer in order to meet the requirement of guaranteed issue? So the Essential Health Benefits Plan is supposed to be that minimum requirement that helps individuals know and issuers know when they have met the requirement to either have coverage or give coverage. So Congress, in the bill, basically laid out 10 very broad categories of benefits which plans must cover if they're going to operate an exchange and sell insurance on the individual market or small group market starting next year. Then they directed HHS to provide more details. In all honesty, HHS basically declined. In December of 2011, they issued it was called a bulletin at the time, or guidance, and they basically said what they were not going to do was define what services and devices were covered under the Essential Health Benefits Plan, but instead they were going to work off what already exists. And since insurance plans largely already operate on a state-by-state basis, they decided they would work within that framework and then broaden it out. So what they said was that a state could choose an existing plan in their marketplace right now, and that the state and HHS would assess that plan to make sure it meets the new requirements of the Affordable Care Act, and then that plan would become a benchmark for that state, meaning that all plans, all small group and individual plans, new small group and individual plans moving forward in 2014 would have to match substantially equal benefits to the benchmark plan in that state. So there is no national benchmark. There is no national essential health benefits plan. Some, I think, would have argued with some evidence that Congress intended a national essential health benefits plan, but HHS, looking at the variety of plans across the country, including the variety of state mandates, took a different course and said, you know what, we're going to do state by state for now, and then we're going to evaluate that process in 2016. We'll see what happens, and then we'll see if this benchmark process has worked. The other thing I wanted to mention is that there's the state-by-state exchanges. Regional exchanges are allowed, though I have not heard that any region is going to have states pair up and offer a regional exchange. And there is something called the multi-state plan program. So the Affordable Care Act allows issuers to offer insurance across state lines. Previously, that has not been allowed, and the Office of Personnel Management is overseeing that program. And so there is the opportunity for issuers to offer the same plan in 50 states and be certified by one governing body, which would be the Office of Personnel Management. And consumers have the choice of purchasing a multi-state plan or plans that are offered in their state. Those multi-state plans will appear on the exchanges just as other plans offered only within their state will appear. So I talked a little bit about how HHS has handed states the role of not only operating exchanges where they can and don't need HHS's help, but also in defining further their essential health benefits benchmark. Not only do they define it, states largely will be enforcing the new criteria. So where they already have strong insurance commissioner offices, or where they already have, say, medical necessity laws, or where they already have network adequacy laws, they'll be expected to continue enforcing those in the new marketplace, and they will also be expected to enforce any new requirements that the Affordable Care Act may have. Where HHS finds states lacking, then HHS will review that and determine if HHS needs to step in. But HHS is largely betting on states being able to enforce the new criteria. I wanted to talk more specifically about habilitation because it has been outlined and targeted by HHS as sort of a mystery benefit, if you will. it's in the language of the law that all issuers moving forward need to treat habilitation as an essential health benefit. But there's large consensus from the regulatory bodies that no one knows what habilitation is. And they declined to define it for us, even though the NAIC and their glossary of terms have a definition of habilitation. And what they basically said is a state can define what habilitation is and require that of issuers moving forward in 2014. Or if the state fails to define or decides not to define right now what habilitation is, that plans operating those chains can choose one of two courses. They can cover habilitation at parity with rehab, which basically means that they can cover habilitation with the same limits as they cover rehab, or they can just decide for themselves what habilitation is and then report that to HHS for HHS's review. For the multi-state plan program, the OPM is going to define habilitation, but we have yet to see what habilitation is under the multi-state plan program. State mandates, there was a big question about what HHS was going to do about state mandates, and basically they made a blanket ruling that said any state mandate in existence before January 1st, 2012 will be included as part of the Essential Health Benefits Plan. There's a cost issue here. The law says that if there are new mandates, or if there are services that are deemed outside of the Essential Health Benefits Plan, the state can require that those services be covered under their state plans. However, the states must pick up the cost of subsidizing those additional services. So HHS has some leverage here for encouraging states not to go above and beyond what they've already mandated. Any new mandates now will be considered in addition to the Essential Health Benefits Package, and HHS and the feds will decline to help subsidize that extra cost in the form of basically tax credits and decreased prices of premiums for consumers that are going onto the exchange and purchasing health insurance, and the state will need to pick up that additional cost. So there's non-discrimination protections within the Affordable Care Act specific to the essential health benefits. And
can you explain that a little more?
Go ahead.
I'm sorry, can you explain that a little more as far as whether the state mandates? Is it a matter of the services that the state mandates or payment things that the state mandates? Can you kind of flesh that out a little bit? I'm not quite sure I understand that.
Okay, so
for instance, Maryland has some things that, you know, that are beholden to Maryland plans, but obviously not to ERISA plans.
Okay.
Would that have to do with who has to be paid and when they have to be paid, and they're in network, they're out of network, and all that kind of stuff? Is that the kind of thing you're referring to as well, or are you just talking about we cover this service, we cover that service, we don't cover this one?
We're talking broader about mandated coverage for specific services. So, for example, Maryland is considered part of the Essential Health Benefits Package now, not just because it says in the law that habilitation has to be covered, but because HHS has said any state mandate for specific benefits that are in existence prior to January 1st, 2012, those will have to be included. Well, those will be considered part of your Essential Health Benefits Package, as long as the state has chosen a benchmark which already requires those mandates. So the mandate for all group plans, basically, to cover habilitation, when Maryland selected their benchmark plan, they selected a benchmark plan which already is required to cover that mandate. And so that will be considered part of the Essential Health Benefit Plan in Maryland. And why that is important, because the plans in Maryland would have to follow state law anyway. So if Maryland had passed a law saying all plans inside or outside of the exchange, regardless of the Affordable Care Act, have to cover habilitation, those plans would still have to follow state law. But why it is important to Maryland is because there's a cost issue. There's certain benefits that consumers can receive when they go onto an exchange that are given to them by the federal government now. So anyone under a 400% of the federal poverty line will receive a decrease in their premium cost. And that decrease depends on how poor they are. And that basically what that means is it's not just they get a lower cost, but the federal government is actually paying the insurance companies the difference. So the federal government will help pay their premium. Now, if they deem that the state has gone beyond essential health benefits and added additional benefits, the feds will come in and say, we will pay the cost of premium that is accounted for the essential health benefits package, but you went above and beyond it, so states, you have to pay the difference.
Okay, but they're setting the benchmark as what is essential is what they've already submitted.
For the most part, yes.
Okay. Okay. Is there going to be such a thing as an ERISA plan that's not beholden? I mean, the people that still have it through their employers or their retirement, are they then going to have to still be beholden to all this stuff?
No. So this is for small group and individual plans that aren't self-insured. And ERISA plans is a little bit complicated, but I believe most of them are not required to cover essential health benefits. If they do cover essential health benefits, they still have to follow the rules on the limits. So basically no plan can have a lifetime or annual monetary cap on whatever benefits are deemed essential. So I believe that ERISA plans still have to follow that rule, but I don't think they have to cover essential health benefits.
Okay.
Does that make sense?
Yes.
And you know, I have answered this question in the past, and I've written something up about it, and I can send that to you. I want to make sure.
Thank you.
I always get it a little bit confused myself, so let me send you the answer that just to make sure I've got it right. But in general, large group plans are not do not fall within a lot of requirements. So these requirements are, the idea is to get folks currently into the market. So this new marketplace is for individuals and small employers. Groups are still considered that. And so large groups, again, are not required to offer essential health benefits per se, but presumably most of them already do. And if they do, if they cover benefits which are considered essential moving forward, they can't have caps on it, and the cost sharing requirements in the Affordable Care Act also apply to those benefits. So there's caps on how much cost sharing a person can spend over time. For example, an individual can spend in a year. That applies to essential health benefits. And large group plans aren't completely free of those restrictions. It applies if they're offering benefits that are considered essential. So it gets pretty confusing, I think, for large group plans. There's requirements around non-discrimination that is in the law that HHS really hasn't expanded upon within their regulations. It basically, what the law says is that essential health benefits can't be defined or must be defined in a way that ensures that such essential health benefits reflect an appropriate balance among categories of benefits, so that one benefit isn't unduly weighted, or that benefits are not unduly weighted toward any category. So there's an inpatient category, there's a mental health category, there's a rehab and have category, there's a pediatric oral category. So the idea is you can't just pile up on one category, on an inpatient category, and offer nothing in the other categories. You have to be balanced across those categories. You have to offer what I would call substantially equal amounts of benefits, but HHS has really largely not defined what this requirement entails. So what we have to go on is what the law says. Plans can't make coverage decisions, determine reimbursement rates, or establish incentive programs designed in a way to discriminate against individuals because of disability. So plans obviously are incentivized to cover healthy people and try to avoid risky populations. I think this is meant to try to get plans to move away from using utilization techniques that end up excluding whole populations of people because they're risky and expensive. Let me go ahead and move on a little bit. There is what's called a summary of benefits coverage document that is now available, as well as glossary of terms. These these benefits are basic, or these documents are meant to accompany information packets that consumers can review when they are purchasing new insurance plans. So it basically is a summary of the 10 categories and non-binding definitions of what those terms mean or what those benefits cover. So, for example, habilitation is defined as healthcare services that help a person keep, learn, or improve skills and functioning for daily living. Examples include therapy for a child who isn't walking or talking at the expected age. These services may include physical and occupational therapy, speech-language pathology, and other services for people with disabilities in a variety of inpatient or outpatient settings.
Would that include a translator or a TTY or a deaf interpreter?
It can include that. Those things are not necessarily excluded by definition, but where the federal regulations and the law fall short is that there really isn't a positive definition unless the state has stepped in and said, this is what we mean by this is what is covered, and this is what is excluded. And honestly, I haven't looked at Maryland's laws regarding this. They may actually have some more specifics when they've passed their exchange law, but I'm not sure that that is true. But it could. I haven't had a chance to look at the newer state laws. And there are states that have gone ahead and defined it for their own plans. So one of the 10 categories of benefits stated in the law is rehabilitative and habilitative services and devices. Federal regulations do not mandate specific services and devices which must be covered under the benefit, as I have said. And as I just said, some states have legislated or regulated definitions and the scope of coverage. So the benchmark plan in each state. Plans operating in exchange in each state must provide benefits substantially equal to those provided in their state's benchmark plan. Although monetary annual and lifetime caps are prohibitive, plans can substitute benefits within the category, place visit limits on the benefits, and use other quote-unquote utilization management techniques. A benchmark plan coverage of this category of services, therefore, can vary. It's dependent upon whether the state has defined it in their law or their reg, and it just depends on how closely those plans follow what's already covered in the benchmark plan. So the Florida benchmark, for example, it's a Blue Cross Blue Shield plan. Right now, they're listed as, it really is unclear from what HHS documents what their inpatient rehab benefit is. Their outpatient rehab is 35 limit visits per year. They say that habilitation is not covered, so that needs to be added. DME is covered with no limits listed. And basically what I've gotten from the material that I have so far in Florida is that we could really use some more specific information from people that are actually in Florida, from Florida providers. And here for a second, I'm going to jump off of the presentation, and I'm going to take you to a website. So this is Texas's EHB benchmark plan. This is Maryland's. This is Nevada's. Well, this is Nevada's Health Insurance Exchange. And this is healthcare.gov. I don't want to confuse people, but I'm going to show you what I do here at Google. And I say, Socio, more information about EHB plans. And I come up with here. So the Center for Consumer Information and Insurance Oversight, this is the healthcare reform office that was created by the Affordable Care Act, and it's now under the Center for Medicare and Medicaid Services. And there's a page on their website where they list all of their essential health benefits benchmark plans. And so when I look to see what a state is doing, I just scroll down this page and I select a state. So we were just talking about Florida. So let me bring up Florida. Now what HHS has done is they have surveyed in 50 states what their benchmark plan covers. This is as of 2012. This is the plan year they're looking at. And so Florida has chosen a Blue Cross Blue Shield plan. Initially, in this plan, habilitative services are not covered. And then what HHS has done has selected a list of services and benefits along the left. And they capped it at 45. And then they have this other benefits. And then they've asked in those benchmark plans to answer certain questions about whether or not this benefit list on the left is covered, what kind of limits, if quantitative limit, a quantity limit, a minimum stay, if there are any exclusions, and then a follow-up question just in case, does this benefit have additional limitations or restrictions? So what the plan did was to answer these questions as of what the plan covered in 2012. That was the plan year they looked at. So as you can see over here, there's a whole slew of services. But when you get down to inpatient, you have inpatient hospital services, e.g. hospital stay, and inpatient physician and surgical services. And presumably, inpatient rehab would be covered under one of these categories, but it's not clear. Then you scroll down, and we have outpatient rehabilitative services and habilitation services. So they've listed specifically outpatient rehab. So that gives us a little bit of clearer information about that benefit. And they have listed habilitation services, and they say that it has not been covered, so that's an area they're going to have to start covering, but they're not defining how yet. And there's durable medical equipment listed as a device. They also have hearing aids, imaging, and then in the other category, they have some other things such as office practitioner, office visit by nurse, and physician assistant. So the other benefits, from what I can tell, is largely stuff that may be required because of a state mandate. And so they've used this area to go ahead and fill in all of that. So let me go back to the presentation. So basically what we're looking at here is this is an HHS document. We're not actually looking at the plan's coverage of evidence document, for example. So providers working within this plan now might have some more specific information about what inpatient rehab services were covered in 2012, for example. So where physicians can help us and other medical professions can help us in Florida help flesh out what's coming or what has been covered in the past, we can then use that to try to help predict what the benefit will look like or should look like starting next year for this new marketplace. Let me see if I can go ahead and get back. Slideshow, there we go. Current slide. So the Maryland benchmark, that's a Blue Choice HMO. The outpatient physical, speech, and occupational therapy is capped at 30 visits per condition per therapy per year. For habilitation, there's the habilitation mandate that pre-existed the Affordable Care Act. That's for birth to age 19, and that includes occupational, speech, and physical therapy, as well as otological and audiological therapy for the treatment of children with birth defects. That's not quite the language that was used, but I abridged it for the purposes of the slide. And then new from the Affordable Care Act is expansion of this benefit, at least in limited form, to adults. So for adults older than 19 entering new plans, small group and individual plans in 2014, if they're older than 19, they can receive occupational, speech, and physical therapy at parity with rehab. So that's 30 visits per condition, per therapy, per year if they're older than 19. And it just lists DME as covered. and we don't have more specifics on the Maryland plan as of yet. The Missouri benchmark, this one's tough. We may have some work to do in Missouri. They have Blue Access Choice PPO medical option. I'm not going to say the whole thing. And in the HHS survey, and remember this is coverage as of 2012, they do have some inpatient services specifically excluded. They say non-covered services for physical medicine and rehabilitation include, but are not limited to, admission to a hospital mainly for physical therapy and long-term rehabilitation in an inpatient setting. Now, I'm not sure what specifically that excludes, to be frank, but I think it would be helpful to talk to our Missouri providers to figure out what the historical experience has been under Blue Cross Blue Shield in Missouri and see if we can speak to HHS about whether these limits will continue in 2014. The outpatient services covered right now there's a 20-visit limit, 36 for cardiac rehab, and lots of restrictions in their exclusion and restriction columns that may or may not stick moving forward. Habilitation is similar to outpatient rehab. It's the parity coverage again. And then DME, durable medical equipment, medical devices and supplies, and prosthetics and appliances are covered without any written limits currently in the HHS document. And I want to, at this point, say that HHS for the federal exchanges and states for the state exchanges are going to be looking at these plan limits and those exclusions and making a determination if some of those limits and exclusions can no longer apply because of the new restrictions under the Affordable Care Act. So some of this information may not be accurate. What we have in front of us to work from now is coverage data that insurance plans submitted in their survey to HHS. It is not the plans that have been approved by state exchanges or HHS. HHS is reviewing those plan documents now. They're going to make a determination later this month. Issuers will have time to provide edits, and then there'll hopefully be a final product in July. But what we have right now is premature. It doesn't necessarily reflect any restrictions that HHS or state may apply on what limits a plan offers. That being said, I think it would behoove those providers who think the current limits that are listed may hamper them being able to provide services in the new market should probably proactively bring that to their attention of their state or HHS to make sure that those governing bodies realize the problem with those limits and hopefully wipe them out moving forward. The Nevada benchmark, limited amount of information. It's a health plan of Nevada point of service groups. Inpatient and outpatient limits are combined. They say they cover quote-unquote short-term rehab services, and it's 60 visits per year. Habilitation is covered at parity with rehab, so that presumably would be the same services covered 60 visits per year. DME is covered with a $4,000 lifetime limit. Right there is an example of a limit that should not move forward. Annual and lifetime monetary caps are now illegal under the Affordable Care Act. So presumably, when this plan is certified when this plan is reviewed by states and as plans are certified and reviewed by HHS, those limits would be removed. Texas benchmark, I think I left in the health plan of Nevada, but the other bullets retained are actually reflect the Texas benchmark and not Nevada. Inpatient hospital and physician services are specifically covered, as they are basically in all of the benchmark plans. But again, inpatient rehab is not specifically listed as a benefit covered within those categories. So it still remains unclear to me exactly where inpatient rehab falls. 35-visit limit on outpatient rehab, same as habilitation, and that includes chiropractic care, according to the HHS documents. Habilitation is covered at parity with outpatient rehab, and also includes, because of a couple state mandates, autism services and benefits for treatment of acquired brain injury. And DME is covered without listed limits. So I want to pause here just to take some questions from folks. It's a lot of information, and I'd like to talk about what folks can do moving forward, but I definitely want to take some questions. Does anybody have anything to add about their state, about what they know so far, what they've experienced? Well, here, let me go over here. So Nevada's running their own health insurance exchange, and they have their own website. Let's see, I also have Maryland Health Benefit Exchange. These are really good sites to get familiar with. They have committees. They have an Implementation Advisory Committee, a Navigator Advisory Committee, Continuity Care. They also take public comments. They have a board. You may or may not know some of these. They have exchange staff. You may or may not know some of these people. If you don't already know them, it would really be good to start to get to know them. I would highly recommend going through these pages, figuring out people that you have connection with, and doing a little bit of outreach in your state. And we can help you do that. But I think it's important that the staff and the advisory committees that are basically implementing healthcare reform have some knowledge of the importance of the services that you provide and where they fall under the essential health benefits package. So then again, Nevada has some health insurance exchange. Again, they have some resources. They have board meetings, advisory committees, community calendars. They probably have some town halls, workshops. All of these states that are setting up their own exchanges, they want them to work. So they are definitely welcome outreach. And the more you can involve yourself in the process, I think the better it will be for the services that you provide and the population that you serve.
One of the problems is, I mean, Maryland just had a big meeting. I think it was on Tuesday. I couldn't make it, and I was going to send my son, actually. He's home for the summer from law school, and he couldn't make it because we were moving my office. But those kinds of things are happening, and it's really, really difficult to find out who the main players are. The western counties are being handled by Howard County, which is more of an eastern county. I mean, and it's just trying to find, even though there's the websites and there's people and all this stuff, and MedChi I know is involved with at least at some level, but just trying to get to the right person to get to the right thing has been a nightmare.
So what have you, so Frank Kolb, I know, is someone that is sort of in the middle of all this, and he's actually giving a talk in D.C. about Maryland's exchange in about 2 weeks. He'd be a good person to reach out to. But what have you, are you just trying to figure out what's happening? Do you have specific questions that you want to get answered?
I don't personally, and I don't do any inpatient rehab, and I do more, a lot of us in outpatient in Maryland do more pain management, and so I haven't heard anything as far as organization from the inpatient guys. We have a big meeting set up, I think it's next week, for the society statewide, and I'll gather questions and we'll try and see, you know, where they want to go with it.
Okay. I mean, I would recommend reaching out to Frank Kolb in Maryland. We can also provide some materials to you if that would be helpful.
Well, I guess the other question is too is that physiatrists are not the only ones that are going to be providing habilitation services.
Right.
Has there been any outreach to any of the others, the orthopedic surgeons, the neurosurgeons, the physical therapy corporations? Has there been any effort to work coordinated together?
Yes, so on the national level, that is correct, yes. AAPM&R is one of the leaders of a habilitation coalition, and that coalition represents all the groups that you've talked about, and also includes children's hospitals and MS and a number of different organizations, the American Pediatric Association. And so we've been coordinating at the national level to provide comments to HHS, and we just recently met with SOCIO, the healthcare reform office within CMS. I don't know that that's going on at the state level, but we'd highly recommend it. And maybe meet with your group, there can be a discussion about reaching out to the other practitioners.
Yeah, I mean, the thing that, as I said, the group that meets the most often and gets together the most often tend to be all outpatient and don't necessarily, some do, some don't own any of their own physical therapy, some do. But from the academy perspective, we tend to feel that they've just kind of ignored us with regard to, Part B or non-hospital outpatient type involvement, both politically and culturally. And if that's something that can be remedied, I think we would really appreciate that. The outpatient services that get provided by the physiatrists themselves that are not necessarily ever done in an inpatient basis.
Well, I think, Sarah, we could talk about that a little bit more offline to see how we could potentially help with that dynamic. I think in Maryland, what do you think about the benefits so far in Maryland?
The benefits are. I don't like the fee schedule, but the benefits themselves are actually pretty good.
Okay. I think in Maryland, what I would predict would be the next steps would be getting some consumer and patient-friendly documents together to share with your patients and potentially to share with new patients about what they can anticipate should be covered moving forward in an individual market where maybe the coverage wasn't as good previously. So I think.
Why would I want to do something like that?
To help bring people into your doors. The idea is that there's going to be a big jump in the number of people who become insured next year that may not have come into your offices because they lacked insurance. And so it's basically a new market. There's an opportunity to serve a bigger population. So by spreading the word that those services should be covered next year, you're basically letting consumers that might demand your services in the future know that their insurance plan should cover it, and if that insurance plan does not, that's a problem and it should be reported. Does that make sense?
It does make sense, but at the same time, I think you've got to understand the population in Maryland as well. Maryland, especially in some of these areas, have the highest per capita income around, and most of the uninsured population are either uninsured by choice because they qualify for subsidized, social medical assistance, or because they're immigrants,
right?
Or they're illegal immigrants,
right? I think also that the idea is, and I don't know how well coverage was in the individual market for Maryland prior to the Affordable Care Act. I think the idea is that even for those that were insured, they possibly were underinsured. They may
be underinsured because they have there's actually the equivalent. I don't know if you like the equivalent of MAIF for health insurance. It's a Maryland Health Exchange or health insurance policy. It's actually run by Blue Cross, but it's not it's separate than a Blue Cross policy. They usually have a $2,000 deductible, and the premiums are they're affordable, but they can be somewhat steep, although they can also get those subsidized. So the individual insurance market in Maryland hasn't been all that problematic.
Yeah.
It's the small business market that everybody's screaming about. And but the reason they're screaming about it is because the premiums are too high, and this is only going to increase the premiums.
Well, I mean, I would argue that this is not going to increase the premiums for small businesses, because they're going to be able to pool into an exchange. That should bring down premiums. It certainly shouldn't cause it to increase. Depends on the age of their employees. Well, I mean, there's no requirement that small businesses provide health insurance.
Right.
The idea is that if they find it affordable, this is another option for them to provide the insurance. So it may be that there is less of a jump in Maryland for the uninsured. I'd have to look up specifically. I did do a profile of Maryland to see. They have made predictions about how many people will enter the market that were previously uninsured. or how many people will enter the market because of the Medicaid expansion. And I can send along those profiles of those states.
I mean, one of the counties in the state, Howard County, has already, they implemented something like this several years ago, and they were willing to subsidize premiums for people and to bring people in to get the uninsured insured, and they projected, you know, so many numbers. There were so few people that signed up for it, and they advertised, they went looking for people to sign up for it, and it never really, it wasn't that it was an unpopular program, it's just that those people weren't there.
Yeah. Well, we'll see. It'll be interesting. I think the other thing to do is I think what we're trying to do at the national level is encourage people on the state level to just monitor what happens, to just go ahead and continue to collect the data you already do, see if anything changes, and then report any problems that we see. In 2016, HHS is reviewing the benchmark strategy again, and at that point, they'll be open to making changes if there needs to be those. But we have to have the data. If we want anything to change in the near future, if there are problems that arise, we need to be able to illustrate those problems in some tangible way. So I think besides disseminating information, potentially to tap into a new market that may or may not be very big, I think the other thing that providers can do at the state level is just monitor. Is just watch what happens and see how it affects your practices, and then report out when there are issues.
Now, is any of this going to change the way that Medicare is handled?
Medicare? No.
Yes.
Okay. No, it isn't. Now, are you alluding to like Medicare secondary payer or just in general Medicare?
Both.
Both.
But let's talk about as a secondary payer.
Okay. So the Medicare secondary payer will now apply to the small group market. So the Medicare will become a secondary payer. The feds have said that small group market is now a group market similar to the large group market, and that MSP applies. They stopped short of saying that MSP applies to the individual market, although that may be in the future, but that's just me speculating. What the exchanges create is a way for insurance plans to pool a bunch of individuals together into what you could conceivably say is a group. And so whether or not in the future HHS looks at that and Congress looks at that and says, well, that's a group now, so we can apply MSP to the individual market, remains to be seen. There's probably some savings there. So that's why I speculate, for the federal government, so that's why I speculate that MSP may be applied to the individual market down the line.
What's an MSP?
MSP, Medicare secondary payer. So
okay.
Right now, if you're in the individual market and you become eligible for Medicare because of the conditions at ESRD, then you can basically go straight into Medicare, and there is no primary payer. It's Medicare only.
Okay.
Your individual insurance can drop, and Medicare picks up the tab. Now, if you're in a large employer market, what happens is, even though you may be eligible for Medicare, that employer will still pay your costs for a couple of years before Medicare becomes the primary payer. And so, that could be the dynamic that changes in the individual market, and it will change in the small group market.
Okay.
Are there other questions?
Teresa, thank you. This has been great, and I actually recorded it for all the folks who couldn't join. So this is some great information.
Okay, great. I would be happy to do this again sometime as we get a little closer to October, when the exchanges will come operational, and in 2014 as all of this starts to unfold. I do think it's going to be important for providers to be just watchful and to make sure that as these things are rolled out, that their services aren't unduly restricted in some way, or that there aren't some kind of dramatic changes in the market that ends up excluding them from the networks that are developed under the exchanges, that for somehow restrict the services that they provide to the consumers, because the consumer can't access the benefit.
And of course, it's important for all of our folks in the state to let us know when things are happening, so that, you know, if you're a more progressive state, we can maybe predict some behaviors for the other states to make sure they're vigilant as to what's going on and how these things are being defined. So anyway, if there's no other questions, thank you all for participating, and I will post the recording of this webinar on the website as soon as possible. Thanks again, Teresa.
Thank you.
Thank you.